Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckbill and I will be serving as your program facilitator and will present your questions to our panel of experts. This evening, Jefferson Health leaders in spine, neurosurgery, and pain management will discuss the latest breakthroughs in spine care and innovative treatments that can help you live a pain-free life. Well, thank you so much for submitting your questions in advance. And the questions that you'll hear me asking the providers are all submitted right from when you registered for this webinar. Now, we received almost 200 questions, so thank you so much for your interest and engagement, and we'll do our very best to get to as many questions as possible. You can also submit your questions during this webinar. And due to hospital guidelines and privacy, we are unable to comment on specific cases. Well, without further ado, I want to go ahead and introduce our experts for the evening, starting with Dr. Tarek Yassin with spine neurosurgery, Jen Malone, CRNP, a neurosurgical nurse practitioner, and Dr. Josh Heller, spine neurosurgery. Well, welcome all. Thank you so much for joining us. And before we dive into the questions, I will give each of you a minute or two to just say hello and provide a little background information about yourself. So Dr. Yassim, we'll go ahead and start with you. How are you doing this evening?
Hello, Sarah. I'm doing great. Thanks for having me. It's a pleasure to be among this wonderful group and working together every day with this wonderful group. And my name is Tarek Yassin. I'm a dual fellowship trained neurosurgeon in spine and functional. I work primarily in the Northeast region, and I operate as well at the Bucks County Hospital with Jefferson, mainly specializing in spine and general neurosurgery in the moment.
Okay. Well, welcome and thank you so much. We're excited to have you.
Thank you. Thank you.
All right. Well, next up is Jen. How are you doing this evening? Welcome.
Fine, thanks. Thanks for having me. My name is Jen. I am a nurse practitioner with 25 years of experience in nursing. 18 of those years I've been a nurse practitioner. Most of my career has been dedicated to caring for the neurosurgical patient. I also have experience caring for hospitalized palliative care patients and patients in the acute rehab setting. I support the spine surgical staff and I see patients at the Navy Yard location and in King of Prussia, and I support Dr. Harrop in Center City location as well as the Navy Yard and in New Jersey.
All right. So you're a little all over the place. All right. Well, welcome. We're excited to have you. Okay. And Dr. Heller, how are you doing?
I'm doing great. Thanks for having me, Sarah.
Absolutely.
Okay, so I'm Josh Heller. I'm a neurosurgeon at Jefferson for now since 2011. So time flies. I've been at Jefferson for a while already. I am fellowship trained, just like Tarek is. I did my training predominantly in scoliosis. So and my passion is adult spinal deformity. So I treat folks who have crooked spines, folks who have had prior spine surgery and still have issues. And I treat the full gamut of everything. Although I see patients out in King of Prussia and the Navy Yard in Center City, all the surgical work is done downtown in Center City.
Okay. All right. Well, thank you. And with that, I think let's dive into the questions, knowing we received so many. So we have a lot to get through. All right. So starting us off with the first question, Dr. Yassin, are there any new treatments or research for chronic back issues or spine surgery?
That's a very good question, Sarah. Actually, spine surgery has been there like forever since the 19th or the 20th century. But most of the advancement happened in the past 30 years, with a lot of advancement in minimal invasive spine surgery, endoscopic surgery, where you utilize small incisions, small disruption of the muscle, and by that, reducing the length of stay at the hospital, the blood loss, and you would accelerate the recovery time. Also, there has been a lot of advancement in robotic surgery, especially with placement of screws. You would be very accurate with that, and thus you get less complications. Also, we kind of like got better at understanding pain generators, especially with utilizing nuclear medicine. And Dr. Heller here is also one of my mentors and pioneer in this field with a lot of research about this with SPECT CTs and understanding where your pain's coming from. Thus, we can help you out with it rather than just shoot everywhere and then you still have pain. Also, a lot of functional advancement in terms of spinal cord stimulators, peripheral nerve stimulators like the cluneal nerve, which wasn't understood before until the past like 10, 15 years. There has been also advancement in pain management procedures. There's like a new procedure or a device called the Intracept, which is the only FDA approved procedure for pain originating from the disc space. Also, I think most of the advancement in the past 15 years were related to spine preserving surgeries by disc replacement or arthroplasty by reducing the pain and not taking the motion of that segment out. Research also ongoing with biologics, the spine mechanism and the stability of it. It has been a wild 10 years, I would say. The past 10 years they have been great.
Okay, fascinating to hear. So thank you.
Thank you.
All right. We will move to our next question here, talking a little bit about some non-surgical options. So, Jen, are there any non-surgical treatments, interventions for individuals with degenerative disc disease?
Absolutely. This is a great question. And I think it's because, the majority of patients that we see in spine clinic, they have some variation on degenerative disc disease. And just to clarify for our listeners, degenerative disc disease is not a disease per se. It's a condition. It's a condition of wear and tear or injury to a disc. And, it starts to develop in many of us. It can start as early as our mid 30s to 40s. For some people earlier than that. And by the time we get into our 60s, many people have degenerative disc disease. That doesn't mean that everybody's symptomatic from it and everybody's feeling pain or numbness or weakness from it. But, if you had 160-year-olds and you put them in an MRI, 90% of them would come back with findings of degenerative disease on their scans. So it's common. We see it all the time. And yes, there are many lifestyle modifications and non-surgical options for treating degenerative disc disease. So kind of moving from simpler to more complex treatments, really it's pretty basic, staying active with some low impact exercises. So we talk about things like walking, yoga, chair yoga, Pilates, swimming, water walking. Water aerobics. And we know that not everybody has access to facilities where they can, go to a yoga class or Pilates class or get into a pool. And not everybody lives somewhere where it's safe enough to go take a walk and walk for exercise. But, having somebody to go to a local high school track with or college track, right? That's an option. Plenty of free online content for looking up at home sort of yoga or Pilates, weight bearing, using your own body weight type of thing. Stretching muscles that support the spine. So strengthening and stretching muscles that support the spine. We talk about core strengthening exercises, lower back strengthening exercises. And some people have, no real idea what I'm talking about. They've never attempted this. They don't know where to start. And for patients like that, we would start them in a physical therapy program where they would get that education. And then they could continue those exercises at home with a home-based therapy program. Or if they're so motivated and inclined, they can continue that maybe at a gym setting. Trying to stay flexible. None of us are that great at this. Just working, not everybody has to sign up for a yoga class, but working in some stretches into your day can really be helpful. Stretching your hamstrings would be great for the lower back. Focusing on what we call a neutral spine position. So, chin back, ears over your shoulders, shoulders over your hips. In other words, keep your head above your pelvis and your pelvis under your head. Keeping your spine neutral like that is important in all the activities that you're doing, walking and exercising. Some people, to try to help neutralize their spine at night, will utilize neck pillows or body pillows to try to, keep their arms and legs comfortable if they're having some nerve impingement or something like that. Learning how to lift properly, how to lift a weight properly. And then once you have that weight, how to move with that weight. So, I mean, I was guilty of this weekend. How many times do we get impatient? We don't want to wait for somebody to help us move something heavy. Or, you taking that weight, holding it close to your core, and then moving safely with that. I think we've all experienced lifting something too heavy and then dealing with acute lumbar strain and a sore back for days and days. And people who are already living with degenerative disc disease or other problems, I mean, you know what you can and cannot do. So avoid what you can't do. If the activity hurts, don't do it. Maintaining a healthy weight, right? Like, this is great for a lot of different health reasons, but if your spine has less weight to carry around and support, it's got less work to do. It's a little happier. And again, we know that when you're in pain, it's hard to exercise, right? So we get it. So following some sort of diet that can help shave off some pounds, it really goes a long way, not just for your back, to your hips, your knees, everything else that has to carry the weight. Stopping smoking, and then eventually stopping all nicotine products. Everybody knows that smoking is not great for your lungs. A lot of our patients who smoke or use gum or patches, they have no idea what nicotine is doing to their spine. And that could be a whole other topic, but nicotine of itself is terrible for the spine. It's so bad. So those are some, simple things that you can focus on. And then, like, other non-surgical treatments, we have plenty of non-opioid medications that you can use, over-the-counter analgesics, topical agents, muscle relaxers, steroids, that kind of thing, heat, ice. And then, of course, our physical therapy colleagues are instrumental in helping our patients with degenerative disc disease who are having pain, whether that's land-based or water-based therapies. And they have all kinds of techniques like traction that they can use, possibly inversion tables. We talk to our patients about chiropractic care, massage, and acupuncture. Some of our patients have found success with mindfulness meditation and breath work. And then, of course, if we've worked through all of those things and we're still symptomatic, seeing our interventional pain management colleagues, they have a host of tools that they can reach towards for all sorts of injections and facet blocks and rhizotomy, or all, called radiofrequency ablation, regenerative medicine therapies like platelet-rich plasma infusions. And these are just some examples.
Okay, some really actionable, helpful tips there. So thank you. Now I want to talk a little bit about surgical options for degenerative disc disease, and at what point should someone consider surgical options?
Yeah. So, I think the first thing that our listeners should know is we try very hard to not bring you to the operating room, to not do surgery on you, right? So, surgery is an option. No surgery is an option. Okay. So not having surgery is an option. Just to keep that in mind. But if we're talking about surgical options for degenerative disc disease, this is a really big topic, and we spend a lot of time trying to figure out what is best for you, what is going to be the most helpful and the least harmful, surgically speaking, to kind of get the job done and get it done safely. So surgical options range from decompressive type of surgeries. We use words like microdiscectomy or discectomy or foraminotomy, and these things can be, or facetectomies. They could be done alone or in combination with each other. And these words refer to the part of the anatomy that's being addressed to, let's say, decompress a nerve. Decompressive surgeries with fusions, bony or instrumented fusions. So all the things I just mentioned, plus introducing, titanium screws, rods, cages, bone grafts, that kind of thing. So those are two examples. Also, Dr. Yassine mentioned, in certain circumstances, when the condition is right, artificial disc replacement. And then also spinal cord stimulation therapy is also a surgery that's implemented to address degenerative disc disease in some cases. I think you asked when somebody would consider having surgery. So, I think it's different for everybody. And, if your symptoms are worsening, if your symptoms of pain, weakness, numbness, certainly if you're developing even more concerning symptoms, bowel and bladder problems with your gait or balance, and that's a different conversation. But, if your symptoms are worsening, If you have diagnostic tests with findings that correlate with your exam and your symptoms, so you have an MRI and a CAT scan and EMG, and the findings on those exams sort of line up with what you're telling us and what we see on an exam. So those things go together, right? So like if you're living with excruciating back pain and you have an MRI of your lumbar spine that's very underwhelming or very like non-specific, and we're not really able to draw the line there, then we have to do a better job trying to figure out why you're living with this back pain, because we don't see it on, the studies we have, right? So again, imaging and diagnostic tests that correlate with your symptoms and your exam. You might want to consider surgery when you've exhausted these non-operative treatments. And again, like your symptoms are worsening and things are escalating that way. Maybe when you've had 2 or more opinions and the opinions are starting to line up, like you're hearing from a couple different spine surgeons and you're hearing the same thing, right? And then the last time you might want to also be considering spine surgery, all of these conditions are being met and you realize that you can take the time off from work or your regular like duties at home, or if you're caring for somebody else, and that you have sort of support lined up for yourself to help you through the recovery of a surgery. So, and our job is to sort of educate you about all of that and very realistically bring you through what to expect, before, during, after your surgery. And so, those are some things to consider when you're taking into consideration when you're thinking about surgery.
All right. Thank you. Appreciate you walking us through that. All right. Dr. Heller, we will turn to you now for the next question.
Okay.
This question here, what kind of treatments show the most promise for herniated and degenerated discs?
All right, so when we're thinking herniated disc, so what does that really mean? That means that the normal inner kind of cushion part of the disc has herniated through. If you think about it like a tire, it's herniated through the harder outer ring, and now that portion that's herniated through into the spinal canal is now pinching a nerve. And so the typical presentation for somebody who has a herniated disc is that they may have done something, lifted something wrong, and now they're having not only some back pain, but pain that will radiate down the leg, often referred to as a sciatica, often a buttock down the back of the leg into the leg and foot, and sometimes it's even associated with weakness. Now, it really depends on the severity of a disc herniation with what is going to be the best management for it. First thing, is that you try to get somebody out of that acute inflammatory phase that goes along with the herniated disc. Your body recognizes this is not normal. There's all these inflammatory markers. The nerves are inflamed. It causes a lot of pain. And so the initial step is, contacting your doctors, getting on maybe a steroid pack or a non-steroidal anti-inflammatory to see if that can help it subside. But if it doesn't subside, then the next step is getting appropriate imaging. And for herniated discs, it's most often an MRI. And then trying to see what non-operative strategies can get somebody through that period of inflammation and can it be controlled well enough that surgery can be avoided. With a disc herniation that's causing severe symptoms, and say a steroid pack hasn't provided much benefit and say nerve medicines haven't helped, the next step typically, if the disc herniation isn't causing tremendous weakness and isn't causing any bowel or bladder dysfunction, things like that are more of a neurosurgical emergency, then it would be for getting an epidural steroid injection, which is a safe procedure that our pain doctors do, giving a needle into the low back in a safe space, not into the nerve itself, but in the area around the nerve. And by giving, I tell people it's like a shotgun blast of steroid right where you need it in order to cut down on that inflammation and hopefully get you through the experience. Typically, we try other things beyond once that is calmed down, some physical therapy, medications that can be for nerve like gabapentin or Lyrica, and non-steroidals. But if those things aren't providing much benefit, and it's a sizable enough disc herniation, it's like someone's pushing right on a nerve and it's causing severe pain. And so surgical treatments become an option. And I tell people that typical non-operative course for a herniated disc is somewhere between 8 to 12 weeks or so. If somebody's having miserable symptoms beyond that and they're just getting, injection after injection or, medications or God forbid going on opioid medications and it's just ramping up and really their life is not going in the right direction, then surgery is really beneficial because most often when patients wake up from a microdiscectomy, which is a small procedure to take away the herniated disc, the first thing they say is thank you because it's a small surgery, tiny incision, and these things can be done either minimal access surgery through a little tube, traditional open surgery, or even endoscopic, as Dr. Yassine mentioned earlier, depending on the configuration of the disc herniation, what it looks like. But most often patients after a disc herniation that have surgery for it, they say thank you because the nerve has been pinched for so long that pressure has been alleviated and they immediately have improvement in the radiculopathy and the pain down the leg. And so I know that there's a fear of having back surgery, but for the things that we do that provide, typically immediate benefit, microdiscectomy is one of the best and most rewarding procedures. Degenerative disc disease is a different entity, although the two things are often connected. Someone had a disc herniation years ago, maybe they had a discectomy, maybe they didn't, and it's just that the disc is worn out and now no longer providing that cushion function, and they have chronic low back pain or chronic leg pain because now the opening for where the nerves come out is narrowed because the disc is now more collapsed. Depending on, how many levels there are, what has been done in the past. I know Jen just went through a whole slew of non-operative strategies for treating folks with degenerative disc disease. But folks can greatly benefit, if, once we've gone through all the non-operative strategies, with for degenerative disc disease, potentially surgeries to restore the normal disc height, whether it be through arthroplasty, which is disc replacement, or through fusion procedures. And, fusion gets a bad rap, but a lot of my happiest patients are folks that have had terrible degenerative disc disease for years and severe back and leg pain and foraminal collapse, and they end up having a fusion, and you're doing it for the right reason. And when you do surgery for the right reason, you have good outcomes. If it's, hasn't been happening very long, you haven't tried all the non-operative stuff, and surgery happens for the wrong reason, well, then unfortunately spine surgery can get a bad rap. And so, I do want people being open to the possibility of surgery, and sometimes that surgery is fusion surgery. But know that we try everything short of surgery beforehand, and then if we're going to do a surgery, we try and do the least invasive type of surgery in order to solve the problem. And sometimes the least invasive surgery seems like a whole lot, but you don't want to give up effective surgery for doing less invasive. And so hopefully that kind of hits home, and we always want to do the right thing. And so Tarek was kind enough to say, hey, I was one of his mentors, but really the one thing I try and teach all of my med students, residents, and fellows is that you really have to listen to people, hear what they have, and really, be a good clinician diagnostician to look beyond just the picture. You treat people, not pictures. And so you have to look beyond the picture, hear what they're saying. Does the picture match what their symptoms are and what they've been through? And sometimes there's other things that cause back pain that isn't from just a degenerative disc. I treat folks who have sacroiliac joint dysfunction, folks who have something called cluneal neuropathy, which, it's a nerve impingement syndrome in the low back. That there's other reasons why people can have low back pain. And so one of my passions is trying to figure that out.
Okay. Well, thank you so much. And I want to follow up with another question for you. So don't go off mute just yet. I want to talk a little bit about managing pain. So if you can discuss pain management options for spine issues, and similar to our last question for Jen, at what point should someone consider surgical intervention?
Yeah, so there's always this balance between, okay, being in the pain management realm versus being in the surgical realm. And we're trying to bring it together because when there's better communication between the non-operative physicians that treat back conditions and the operative surgeons like myself and our team, then we'll have better outcomes. And so we try and have this good back and forth because we don't want people to be lost into this hey, they have chronic pain, they go to pain management and they're just given medications, or that they're just given, relatively ineffective treatment after ineffective treatment after ineffective treatment. But pain management physicians that are listening to you and doing things for the right reason can have wonderful results. And they help us tremendously with getting through some things that don't necessarily need surgery. And so, as I mentioned before, with the treatment of a herniated disc, it's both of us together, getting somebody in to get that timely epidural steroid injection, which could be all that they need to get through the inflammation. Or if somebody has degenerative disc disease and figuring out where the pain is coming from, if it's predominantly back pain, is it coming because the disc is degenerated? Or is it because that the facet joint, which is the joints in the back of the spine that help with the motion, are they the culprits? Are they arthritic and causing pain? Because if it is, well, then there's some things that the pain management physicians like Dr. Truitt can do with kind of facet injection, seeing how well that works, then potentially providing an ablation type of procedure. Ablation just means there's a little nerve ending, not the main nerve, but the little nerve ending going to the joint of the spine. And if you provide some energy and make it so that nerve isn't functioning as well, you may not feel that arthritic joint. And that could be all the treatment that you need. And ablations can work wonders, and they can provide lasting relief, which is a wonderful thing. Tarek mentioned earlier the Intracept procedure. Intracept is a newer procedure that some of the pain management folks are doing for folks that have pain that's coming from the front, from either the vertebral bodies or the disc space that are causing pain. And it's a ablation of the little nerve going into the vertebral body and the disc. And it's a way of helping treat that pain. And then there's some newer procedures that are being done with, and some of it's not quite ready yet, but folks are exploring PRP injections into the disc or biologics into the disc, because the goal long term is to say, okay, how the degenerative process happens. How can we take those folks when they're early enough on to try and make it so that they don't necessarily need the fusion procedure later on, that they don't necessarily need me. And that's going to be the future of all this. And we're all researching that. I wish stem cells panned out, but so far stem cell injections into the disc have not done that. But we're looking into new ways of trying restorative therapies short of surgery. And so, having a great relationship with our pain management physicians, it's wonderful, but also kind of recognizing that folks shouldn't be stuck in this, hey, chronic pain realm of just opioid medication or chronic medication or procedure after ineffective procedure after ineffective procedure.
Okay. All right. Well, thank you so much. All right. Moving along here to our next question. Dr. Yassin, we will go back to you. How can drop feet due to spinal stenosis be fixed? And how can chronic lumbar pain be fixed when injections and therapy just don't seem to work?
So to start with that, we have to understand how does a drop foot happens. Nerves stem in your back and then they travel and join each other into groups. We all have heard of the sciatic nerve, which is a group of nerve roots that join together. It's the major nerve that supports the muscles of the leg, and it branches at the level of your knee into two major branches. One of them is very superficial, and this could be damaged by trauma, which could also, if you sit cross-legged for a long time, it could happen to you that you develop a drop foot. And then it goes all the way down to support the dorsiflexion muscles of the foot. So if the nerve is damaged, that means that the muscles have no innervation enough to give you the strength that you need. And we have to distinguish between the causes of that. One of them is simple compression due to the stenosis or disc herniation, due to irritation, inflammatory process, or just like a trauma. The neuropathy could cause that, the diabetes, among others. So not every drop foot could be easily treated. And at the end, like Dr. Heller said, you have to look at the images and relate to the symptoms because sometimes you have a lot of imaging findings without symptoms. So you do not treat the imaging at the end, you treat the symptoms. But I like the analogy that says if you have a big rock in your way, then you can't move your car. So you have to move that rock out of your way in order for you to drive. And if something is compressing the nerve root that supports the dorsiflexion, which is most of the time L4 or L5, then you need to decompress it. Sometimes just with steroid injections, with physical therapy, you will regain the movement and the strength of your foot, even without any surgical intervention. So I like to consider ourselves as a very conservative group. We like to see a benefit of our work. We like to put you through the risk of surgery to see a result at the end, not to have just a complication for nothing. And we don't want to see you at the office every 2 weeks coming with the same problem and complaining to us. That's the worst thing we could see. We just want to help you. So a surgical intervention is usually simple with a decompression, shaving the bone off the nerve or taking the disc out. Sometimes with the disc prolapse, like Dr. Heller said, the nerve exiting canal, the foramen, is narrowed. So we have to jack it up open and do a fusion maybe. These are mainly the surgical options. And I always ask my patients, how miserable are you? Have you tried everything possible to avoid surgery? And usually over a period of 6 to 10 weeks or 12, if they say so, then there is something that is made for your problem to solve it. And it's up to you to go for it or not. It depends on how miserable you are. So after injections, physical therapy, and I think that Jen covered it all very nicely with the aquatherapy, the Pilates, many, many options. Then you could jump into surgery if you feel miserable enough. And for us, we only indicate surgery if you have one of the red flags, such as a weakness, sensory deficit, bladder, bowel dysfunction, what we call a saddle region anesthesia, that's numbness in your genital area. It could cause sexual dysfunction, many, many problems that you could avoid by just seeking for help.
All right. Well, thank you.
You're welcome.
And before we turn to the next question, just a quick reminder, if you have any questions that are popping up for you during this discussion, feel free to just drop them in the Q&A, and we will be getting to live questions in just a little bit. But for now, we'll move through a few more submitted questions. So Jen, turning to you now, can you address treatment success rates for sciatica?
I think a lot of the answer to this question sort of piggybacks on a lot of what Dr. Heller and Dr. Yassine already mentioned. Dr. Yassine, when he addressed the question about foot drop, really walked us through the anatomy of the sciatic nerve, where it is, where it goes, what it does, what its function is. So to simply answer the question, most cases of sciatica can be successfully managed or even totally eradicated non-operatively. I think this tends to be more the case with acute or subacute cases of sciatica type pain, but even people living with chronic sciatica, they can have their pain lessened or even cured with all of the things, the non-operative strategies that I discussed when we were talking about degenerative disc disease. We'd like to say that, just for a quick example, let's say an acute disc herniation is the cause of your sciatica right now. We know that non-operatively, patients who elect surgery and patients who elect non-operative treatment, at the 12-month mark, most people have the same outcome. So, for people who are deciding to treat their sciatica non-operatively, it can take 3 or 4 months, but they might, they'll get there. And surgery is really just reserved for severe cases that don't respond to conservative treatment, or when there's neurologic defects such as Dr. Yassine discussed.
Okay. All right. Thank you. Okay. Dr. Heller, we will turn to you now. After surgery, can hardware shift cause neuropathy?
So with putting in instrumentation, it shouldn't shift. So if there's a movement compared to when it was first put in to where it ends up now, then there's something that is a problem. So oftentimes, if somebody has, it looks like the screw may have moved or has lucency, which means loosening on the image on the X-ray or the CAT scan, and now it's causing compression. That's a problem because it's an indicator that there's a failure of the fusion. So the screw was put in you can think about screws and rods, internal instrumentation, like an internal brace that's meant to hold things still while the bone mends together. We're essentially asking bone to grow where God did not intend it. There used to be a disc, there used to be a joint. We're now asking for fusion, bone to heal through those spaces. But if fusion doesn't occur, something has to give. And so if the bone is really solid and that there's still motion through the segment, what could happen? Well, the rods can break. And so I give the analogy of a paper clip that you bend a paper clip back and forth a couple times and it'll break. Well, a titanium rod that's 5.5 millimeters in diameter is a lot stronger than a paper clip, but you cycle it a couple million times with all the motion, eventually it breaks. Well, somebody who has weaker bone, that maybe osteopenia or osteoporosis, well, the screws and rods are solid, but the bone may not be. And so the screws start acting like a little chisel and it can hurt a whole lot when you lean forward or lean back. And then, it can lead to recurrence of stenosis and narrowing and pressure on the nerve. So the answer is yes. If a screw is shift, can it cause nerve or neurologic issues? The answer is yes. Should it have shifted? No. If it has, there's an issue and we can fix that.
All right. And I guess into that next point there, how can you fix that? What are remedies for this?
Well, unfortunately, if somebody has a true pseudoarthrosis, a failure of fusion, and instrumentation is no longer in the right position, well, unfortunately, an injection is not necessarily going to solve that problem. And so that's where, revision strategies come in place. But, getting back to hey, what was the underlying etiology of it in the first place? Somebody has weaker bone. Maybe we need to put somebody on medication for osteoporosis first in order to improve their bone quality. And the definition of insanity is doing the same thing, again and expecting a different result, right? We want to make sure that we take care of all those factors that may lead to the adjacent problem or the next problem down the road. And so we do lots of things to try and avoid further, spine surgery down the line.
Okay. All right. And Dr. Heller, one more question for you here.
Sure.
For someone who has nerve damage in the lower back, are there exercises that can be done safely to strengthen?
Oh, of course, of course. And I know that Tarek and Jen have been talking a lot about non-operative strategies too. We mentioned neurosurgery, spine surgery, and pain management, but rehab medicine is such a huge part of what we do too. And we have such wonderful relationships with our PM&R physical medicine rehabilitation colleagues and physical therapists and such, that if somebody does have a neurologic deficit, a nerve damage, that working with them in order to strengthen. And the future is out there. There's things that Dr. Tarek Yassin is doing with spinal cord stimulation to even help folks who have had, spinal cord injuries. And so the future is out there as far as what can be done from a rehabilitation standpoint, both through traditional rehab, physical therapy means, and also through surgery and modulation.
Okay. All right. Thank you. Okay, Dr. Yassin, turning to you now. We received a question about a multiple myeloma diagnosis. So it says here, due to a multiple myeloma diagnosis, there are many lesions throughout the skull and spine. What are the best ways to maintain bone integrity? And is there anything that can be done if there is total bone loss?
Multiple myeloma is kind of a cancer or a tumor. It's a blood disorder that results in it results in an increase of monoclonal immunoglobulins, which is a kind of white blood cells, and it causes lytic lesions all around your skeleton and your skull. The good thing about it that it's radiosensitive, but you need to diagnose it first. And unfortunately, it happens with older group of population where you also have a decrease in the bone density, which also decreases generally after the age of 60. Your age, your body ages, so is your bone, and it doesn't replace cells as it used to be when you were young. And also, it results in calcium release into the bloodstream that further damages the bone and ultimately leading into osteoporosis and pathological fractures, which are fractures that are caused by tumors rather than caused by trauma that usually happens. There's a measurement for bone health. We use a DEXA scan commonly at the femoral head, which is the biggest bone in your hip. And if it's less than minus 2.5, then that's considered osteoporosis. And there is a degree before that caused osteopenia, which is measured from minus 1 to minus 2.5. And usually at the level of osteopenia, you have to make sure you look after your bone health, usually by diet, by having regular exercises, supplements such as vitamin D and calcium. Then, after you get into the osteoporotic range, we could give medications. Now, the medications and the treatment of osteoporosis is usually managed by endocrinology and rheumatology. We have to be aware of this. And these people or these good doctors, they could prescribe you medications. The first line is usually bisphosphonate. Mainly, the medications are targeting two cells in the bone. There is one cell that causes the resorption of your bone, like when you have some dead bone cells, they have to be removed. And the name of the cells are osteoclasts, and there are some cells that build your bone. So to help improve your bone, you have two options, either by stopping the cells that cause the resorption or by augmenting the cells that cause the bone building, which are the osteoblasts. You have to avoid malnourishment. There are some diseases that could cause osteoporosis, such as the thyroid diseases. Steroids are a major factor that affect the bone, and we have a large population with asthma, with lung diseases that uses these medications. Females are generally more prone to this disease. After the age of 60, if you're so skinny, then this puts you at risk as well. And most importantly, like Jen said, smoking, nicotine, and alcohol as well. You can do some lifestyle changes, like I said, such as diet and exercises. If you smoke, you have to stop smoking, alcohol cessation. Like you could target the primary culprit that is causing it. If you don't find any primary culprit, then you could get medications when you reach the osteoporotic range, such as the bisphosphonates. There are new medications. Injections that you could get every 6 months, some of them every 3 months. And like I said, these are mainly used by endocrinology and rheumatology. If you lose your bone, there's really no way to replace it. Like we can't inject bone cells inside. Maybe in the future with stem cell research that we could come up with bone cells that we can inject. But in the meantime, you rather just take care of yourself, look after your diet, and do regular exercises.
All right.
And also the menopause, just a reminder, because the sexual hormones, they're protective. So women at the menopause, they lose the estrogen, and that's really protective. So some people use hormone replacement to strengthen the bone.
Okay. Some really helpful tips. So thank you for walking us through that. With that, I want to go ahead and
Yeah.
jump to the live questions because I know we've been receiving a ton. So thank you all. So I'll go through, read the live questions. But certainly this is meant to be a discussion. So feel free to chime in as you would like. So with that, for the first question, Dr. Heller, I will direct this one to you. What is a spinal deformity and how is it treated?
So spinal deformity can refer to a whole lot of things. I think the simplest way to think about it is that there's some disturbance in the normal alignment of the spine that prevents somebody from being able to stand comfortably. And so, if you think about how we stand, we want to stand with our head over our pelvis, over our feet. And if something has changed from a mechanical standpoint that we can no longer stand that way, then somebody has a spinal deformity. The classic deformity that most people have heard of, it would be a scoliosis. And there's different types of scoliosis. There's scoliosis that affects people that as they're kids and going through adolescence, and then there's scoliosis that happens to a lot of folks as they get older in life with more of a degenerative condition. And some of those kids, all those kids become adults, hopefully, and the folks with adolescent idiopathic scoliosis can have a worsening of their spinal deformity as they are an adult as well. Typically, adults can tolerate some shift side to side reasonably well, but disturbances in what's called the sagittal plane or the side view, when people start becoming more hunched forward and kyphotic, that's a harder thing to handle. And so there's deformities that involve the neck, there's deformities that involve the back, and sometimes it's a global alignment problem, and sometimes it's a focal problem, like a spondylolisthesis. So some of you may have heard of a spine slip where one bone is forward compared to another, and that's a type of a spinal deformity as well.
Okay. All right. Thank you.
Sure.
Okay. Jen, question for you here. When does it make sense to get a second opinion for chronic back pain?
I think that's different for everybody. I mean, I think getting a second opinion, regardless of what the underlying condition is always a good idea. Um, it could be that the person who's asking this question or the patient who's interested in this is maybe feeling like they've reached a dead end or they're not necessarily getting the answers to the questions that they want. I would suggest talking to somebody, and also more importantly, make sure that you're coming in with the most updated studies, because that could only be helpful for the person who's looking at you for a second opinion. We see tons of patients for second opinions, and we send our patients out for second opinions, in fact.
All right, thank you. Okay, next question here. Dr. Yassine, question for you. What are effective spinal injections and spine stimulators for pain?
So injections they start usually the pain doctors with the epidural. There are different types of injections. There are like trigger point injections. There are injections to the facet joints. There are sacroiliac joint injections. You really have to know where the pain is coming from in order for you to target it. There is one injection that I sometimes like to use, both for diagnostic and therapeutic purposes, just to inject the nerve that I think is causing the pain by going there into the foramen with the use of fluoroscopy or X-ray, and just to target this nerve with steroid as well. Stimulators are usually used to kind of deceive your brain that your brain would think that your legs are good. There's no pain coming from your legs up to your spinal cord and all the way to your brain where the sensation of pain is generated. This has been a lot of advancement in terms of diabetic neuropathy. The pain that wakes you up at night, what we call a neuropathic pain, especially it could be back pain, it could be leg pain, like the feet, they're getting numb. A spinal cord stimulator would help with that as well. There is a stimulator for the cluneal nerve that Dr. Heller is very, very advanced in this regard. Like he's one of the most experienced people maybe in Philadelphia in that regard. So you can target that with a stimulator just to stimulate it, And a lot of patients are happy after that. Like I said, you just have to know where the pain is coming from. If you diagnose it right, you're able to treat it. It's very easy to treat it. If you don't know where it is coming from, it's just holding a shotgun and just like shooting everywhere without knowing what you're doing.
Okay, thank you. All right, next question here. Dr. Heller will direct this one to you. How often is the SI joint the pain generator, and what are some treatments?
So I would say the SI joint is the source of pain more common than a lot of people think. So just a little bit about sacroiliac joint anatomy. The SI joints are the largest joints we have in our body. We need to transmit the weight of our body, the weight of our trunk, from our spine through our pelvis to our hips and lower extremities. And the SI joints allow us to do this. And so every time we take our step, the entire weight of our body is going through our SI joint. So the SI joint is a really large joint, and it's got a complex anatomy. It's got a bony surface, it's cartilaginous, and then there's a very strong ligamentous architecture to it. Typically, SI pain is a little bit different than your typical low back pain. And so folks who have SI pain, the pain is low down, but maybe not right in the middle, maybe a little bit off to the side. So if anyone, grabs their low back and feels off to the side, you'll feel a little bump there. That bump is a portion of your pelvis, but pain will often radiate to that spot. SI pain can cause more pain when you sit, oftentimes transitioning between sitting and standing, rolling in bed. Now, there's this false thought that SI pain should only be in that spot. That's not true. The pain often radiates, and it'll radiate down the leg, and it will often mimic a radiculopathy or a sciatica, and it can go down the leg and into the foot. It can go into the hip and groin too. We differentiate SI pain from other causes of low back pain, typically based on history and then on physical exam findings. There's certain things that we can do, pushing and pulling on the pelvis, and I teach this to my residents and fellows. So Tarek got a lot from me as far as how to diagnose sacroiliac joint disorders. But then we work with our pain doctors to really confirm that that's the source of the pain. So if you numb into that joint, if you give an injection of a local anesthetic into that joint, and it takes away your pain dramatically, then you know that that's where the pain is coming from. There's a treatment that I do and that other spine surgeons do, where we can actually do a minimally invasive approach to the fusion of the SI joint. And it's one of the most gratifying things that I do, and if people really do have it and we prove it, that the treatment is, pretty standard on how I do it and what it takes to get through it and heal. And so some of my happiest patients are folks that I've treated for SI joint pain. And these are folks that thought they had a bad back for a very long time. They went and had lots of other things done. They may have even had a spine fusion and it didn't work. But all the while, it's been this SI joint. And, why people have it? Well, trauma is probably the most common reason. Somebody gets into a minor fender bender or stumble. You can think about pregnancy as being a traumatic event to the SI joint. It's a little bit more common in women than it is in men. And that has to do with how the pelvis expands during childbirth. If you think you have SI joint pain, it's worthwhile to kind of see somebody like myself to get it evaluated and to say.
All right, absolutely. Thank you.
No.
Okay, next question here, and we're receiving a lot of them, so thank you all. Jen, question for you. What can be done for stenosis which goes down the leg?
Okay, so I think, again, stenosis. So if stenosis is a narrowing, an overgrowth of bone, a lot of times it's from a combination of things like arthritis building up, or maybe the nerve has a little too much arthritis around it and a bit of a disc bulge. Treatments can range, again, from all the non-operative strategies that we discussed. A lot of our patients that we are meeting with radiating leg pain and stenosis on imaging, we will refer them for some physical therapy, and we will refer them typically to a pain management physician to have an injection at that level. to be evaluated. Maybe they need an injection at 2 levels. Maybe they need it on both sides. And those injections, if they're helpful and they're happy with that, and sometimes it takes 1 injection, sometimes it takes 3, sometimes the injections aren't that helpful, then we bring them back in and we talk about surgery to address the stenosis. Again, we try to get away with sort of the least invasive surgery as possible. So if it's as simple as decompressing the area around the nerve that's been getting pinched, that's causing that leg pain, then that's a surgical option. But if they have an underlying issue, like Dr. Heller had mentioned, spondylolisthesis, a spinal deformity issue, then we usually start getting into discussions about decompression and fusion.
Okay. All right. Thank you. All right. Next question here, Dr. Yassin, we will turn back to you. This person is wondering, what is the latest in treatment for AS spondylitis?
Spondylolisthesis, it has many treatments. You have to rule out an instability at the beginning. If you have an instability at that level, then probably a fusion would make more sense than doing any other procedure that would accentuate the instability. We find out if the level is unstable by performing a simple dynamic X-rays where you bend forward and backward. We call it flexion extension. And if you find out that the pain or this level is unstable, where it moves whenever you move and bend your back, then it's moving with you and it's causing you pain, then a fusion is the most reasonable treatment by going forward. Some of them, they do not move. And in that case, there is a treatment where we place like a clip. We call it a Coflex, where we do a decompression. We release the nerves from any pressure, and at the same time, place a small clip from the back to help with fusion. And by that, when you fuse this segment, then probably you will just solve the pain at that segment. If you don't want to have any implant inside your body, then you can just decompress the nerves and shave the arthritis off the nerves. But that has to be done if you don't have any instability. And also, if you have an instability and you don't want to have a fusion, then we can do a decompression. We don't recommend it. But at the end, I like to go by the patient. Whatever the patient wants, we'll just do it.
Excuse me, Sarah and Dr. Yassin, did the beginning of that question say AS spondylitis? Okay. So
Correct.
Dr. Yassin, excuse me. I think part of that question, the person who asked it was asking about, I think, ankylosing spondylitis. I don't know if that changes.
Yeah, it changes a lot of things. I take everything back.
Thank you for the clarification, Jen.
Yeah, the ankylosing spondylitis is mainly a type of disorder. It's a rheumatological disease that causes the ossification of the ligaments and the disc space. And these people, whenever they get a minor trauma, they tend to get some fractures. And when you want to approach their fractures, then you have to do a long segmental fusion because the arm of force is big, and they don't have any elasticity of their back. They can't bend forward or backward like other people would do. But in terms of any surgical intervention to release the nerves, it's basically the same. I think the main issue is when they have a fracture, then you should approach them in a different fashion.
Okay.
Thank you,
right.
Jen.
Yes. Thank you.
And
All
just
right.
to chime in on the ankylosing spondylitis thing, yes, it can be a cause of back pain. The most common treatments are going to be with the medications from a rheumatological standpoint, but ankylosing spondylitis can be associated with spinal deformity. So having a spine that's fixed, but also fixed in a bad position. So with a kyphosis, and in those settings, we can do surgery for fixing the deformity. And then also ankylosing spondylitis is associated with sacroiliac joint pains too. And so, there's some things that we do for that as well. Although we try and treat true ankylosing spondylitis first with medications as opposed to with surgery.
Thank you. All right, Dr. Heller, I will direct this next question to you. What can be done for severe disc degeneration and curvature for people over 80 years old?
So age is not necessarily the factor that stops you from having a treatment. It really depends on a lot of things, on bone health. So if you have an osteoporosis, if you have a lot of medical comorbidities, surgery may not be the right thing to do. I treat some folks that are in their 80s and sometimes in their 90s that have spinal deformity with surgery, and it really depends on the person and what they have. There are factors that we think about. If somebody has osteoporosis, we'll put them on medications to help with their bone quality and keep them on those medications for several months before doing a surgery. Of course, we like to try and do the least invasive thing that's going to be able to solve the problem. But sometimes it takes a combination of less invasive surgery with maximally invasive surgery in order to get the best outcome possible. And so I don't want, the take home should be that no, age shouldn't be the thing that totally says you can't have a surgery for something. It's your medical comorbidities and frailty and other things of that nature that say, is surgery safe for you to do? And if surgery is safe to do, if we go through all the medical clearances, the cardiac clearances, and we're doing surgery for the right reason, you can still have great outcomes because, people live a long time. People are healthier, if you have a deformity, if you have a scoliosis and can't stand up and can't walk, well, and you're not getting to enjoy your 80s other than, if you have a good heart and everything else is okay, then surgery may be the right thing. Lots of studies have shown that patients that are the sickest with the worst deformity and the worst perceived quality of life, they're actually the ones that have the most perceived benefit with these big deformity surgeries. And so even though the risks are great, some people want to take that risk. If you'd rather be dead and then be the way you are, then, that we shouldn't be not listening to you and thinking about it. The reality is that if you're healthy enough to have a deformity surgery, that we'd be willing to do it. It's just, a matter of making sure we optimize everything and try and have the best possible outcome as a result of it. But no one should discriminate against you because you're in your 80s.
Absolutely. Okay, thank you. All right, for our last live question here, and I think we've touched on it a little bit throughout this conversation, I will turn to Jen, and then I have just one final question before we wrap up with the evening. But Jen, this person is wondering, when a patient has tried injections, ablations, opioids without helping my pain, what should I do next?
So, again, come in, make an appointment, talk to us. We will listen to you. We will do our best, as we always try to do. Determine if you need some, update in imaging, evaluate you, examine you, figure out, is it coming from your spine? Is it coming from your hip or your shoulder? Or, I don't know. It's a pretty general question. And the options, as we discussed tonight, we covered a lot. There are many, right? And they don't always end in surgery. In fact, like I said before, we try to keep you out of the operating room. For a surgical practice, we spend a lot of time trying to keep you out of the operating room. Come and see one of us. We're here, we're available, we're all over the place in different locations. So yeah.
Okay, perfect. And I think that's a great segue into the last question of the evening. So for the final question of the night, what are your goals for everyone listening in on this webinar? What would you like our viewers to take away from tonight? So Dr. Yassin, we'll go ahead and start with you.
I think that back pain is a very common problem, and studies have shown that 90% of the population will suffer of back pain at some point of their lives. If you have back issues, reach out for help. We will work it out for you. If we find a reason behind your back pain, we will help you out with it. If we don't find it, then we will be like, we looked it up, and I don't know where your pain is coming from. And that's only in a minority of the cases. We got better at understanding pain generators. If you do it for the right reason, you will be happy. If you don't do it for the right reason, you will get what we call a failed back syndrome. And it's like a domino effect. You just start and never stop at some point because one surgery would lead to the other. Um, and I see a lot of my patients who have bad experience of back surgeries throughout their relatives or their friends. Don't let that affect you. Uh, think about it, seek a second opinion, and try everything you could to avoid surgery if you could. But if not, then surgery is there for a reason.
All right. Well, thank you.
Thank you.
Okay. Jen, any final remarks from you?
I guess just my goals for anybody listening is, we know that many of you are living with conditions that are uncomfortable, painful, life limiting, your quality of life is suffering because of it. You've tried many things. Maybe you've tried nothing yet. You're likely scared, you're frustrated. It's difficult. And you come into our practice and you meet us, and, just know that there's not always an easy fix to it. There's not always an answer. I think people show up and they're hoping for, okay, we see what the problem is. It's really straightforward, and this is what we're going to do, and you're on the OR schedule, and then you're going to be great in 3 months from now. And that is not often the case, and it's not us trying to make things even more difficult. Just know that we're always at the root of all of this. We are trying to be helpful and not hurtful. We want to make your situation better, but we don't want to harm you in the process. So, and it's a process. So I think that's my goal, is for people to hear that.
Absolutely. An important reminder. Thank you. Okay. And last but not least, Dr. Heller.
First off, I'd like to thank you guys because I think you did a great job, Sarah and David and everyone else from the marketing team. I think this has probably been very helpful for lots of folks out there. And I know I see that there's lots of stuff in the Q&A out there, and I'm sorry if hopefully we can get to type some of those answers back if we're as we're running out of time for the actual spoken portion of this. But for those of you that had still questions and such, please do reach out to us so that we can try and answer them all. Really, I hope what you get from this is that that there are answers, and you just you need people to listen, and you need people to kind of really hear what you're saying and complaining about, and not necessarily just to look at a picture and say, no, that looks, there's no narrowing there, you're fine, go off. There's so many different, the spine is complex. There's so many different reasons why people have, pain or weakness or sensory loss or all the other, things that we are treating. And we have to hear you. And sometimes it's things that are not surgical. And sometimes it's things that are not even, in the realm of what we should be seeing you for. But we can at least hear you and say okay, okay, this sounds like a neurologic condition, and we need to get you to a good neurologist or to the right folks. And so, it's not a just fast food service here. This is something that takes time to understand what's going on. And so, please do be patient with us. That, like, I know it takes a while to get an appointment to see some of us. And please do be patient in the office. I know sometimes I'm running behind, but understand why. And we're doing our best to give the best possible care for everyone that's in our community. And obviously, feel free to reach out to us. I'm sure the marketing team will show you how to get appointments with us. And it's not just me; it's our whole team. And we're here for you.
Absolutely. And yeah, links have been shared in the chat. So
good.
Easy enough. Yeah.
And yes, we do have locations in New Jersey, King of Prussia, in the Northeast, Delaware County, all over the place.
All right. Well, thank you. Thank you so much, Dr. Yassine, Dr. Heller, and Jen, for your time this evening. I know such great information was shared. And like Dr. Heller said, thank you all for attending and submitting your questions. I know I learned a ton, so we really appreciate it. We will be posting an event survey so you can let us know your thoughts. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please go ahead and fill out the last question in the event survey. A recording of this event will also be sent to you so you can rewatch at your convenience. And if there is anything anyone here at Jefferson can do for you, please reach out to us. Once again, thank you for joining, and please be sure to stay safe and healthy. Have a wonderful evening. Good night.